Hi, welcome to this 5-unit module on second messenger modifiers, uh, also known as mood stabilizers. My name is Andrew Penn. I'm a clinical professor at UC San Francisco School of Nursing. So before we get into treatments, I want to talk for a little bit about understanding the diagnosis of bipolar disorder better. And we'll circle back to the differential diagnosis in a later module. But for this first part, I just want to get clear on some terminology. And in this series of modules, we're going to be thinking about bipolar disorder as somewhat of a spectrum, and then thinking about how to use these second messenger modifier drugs as the cornerstone of treatment for bipolar disorder. So these are things like lithium, valproate, and lamotrigine. And really, I'm going to be interspersing throughout the talk ways that I talk with my patients about this condition so that you can adapt that to your own clinical needs. So let's get clear on vocabulary. Sometimes I will actually draw something kind of like this with patients. I'll take a blank sheet of paper and I'll draw a line across the middle on the horizontal axis. And I'll say, you know what, this is what we call euthymia. So it's as much as we can call anything a sort of a normal mood, because it's important to understand that, mood variation is just part of being human. It's really when it gets to the point of causing clinical impairment do we start to think of it as a disorder. We all have good days and bad days. So just to get clear on what some of this terminology means, so that middle line through the horizontal axis is euthymia. And I think most people are familiar with the idea of depression, and depression can exist to varying degrees of severity. So we might call a sort of a moderate depression a dysthymia. That also sort of refers to kind of a chronic low-grade depression. And then a severe or major depressive episode would be considered, sometimes referred to in the bipolar literature. I believe it's referred to in the GAMI book as a pure depression. So, this is, I think most of us are familiar with what that looks like. Obviously low mood, anhedonia, in bipolar disorder, usually significant changes in energy levels. So typically somebody's going to need a lot more sleep and they're still going to feel tired and sluggish. And then on the other side of the line, the upper side of the line, we have what we refer to as hypomania. Hypomania may not be visible to other people, but it definitely will be felt by the patient. They'll feel like their thoughts are going faster, they're more goal directed, they're more generative, they're coming up with a lot of ideas. And as that hypomania goes into full mania, it will become more observable to outside observers that something is going on with this person because they'll often be talking very quickly. They'll often be kind of moving from thing to thing. They'll have a lot of goal-directed activity. They might actually be difficult to follow their thought process. And that is what is known as pure mania. And if you've seen that in your clinical practice, you definitely know what I'm talking about because it's sort of like witnessing a seizure. When you've seen pure mania, it's really a force of nature and you tend to remember it. Um, and there's this kind of odd shape in the middle here known as mixed features. And this is an important concept to understand because it's a little counterintuitive. I think a lot of people, when they think of the bipolar diagnosis, they think either or. Either you have depression or you have mania. And the reality is that oftentimes people will get this kind of combination of features of mania and features of depression happening simultaneously. So what that clinically might look like is somebody is having a lot of dysphoric negative thoughts, but they can't turn them off. They're just going over and over and over again. It's disrupting their sleep. They might feel agitated, but not in a positive way. This isn't kind of like an excited sort of way. It's a really uncomfortable feeling. It can kind of feel like you're driving with your left foot on the brake and your right foot on the gas, and you're pushing kind of both pedals simultaneously. So the engine's revving, but you're not going anywhere. High risk for suicide in this state because it's so agitating and uncomfortable that sometimes people really just cannot tolerate that sensation. It's also worth noting that this concept of temperament in the mood disorder literature. So we refer to sometimes a hyperthymic temperament. Temperament doesn't rise to the level of a disorder. It's more kind of how we are wired as people. And you see this in young children. You see children that are very energetic. They've got a lot of enthusiasm. They're very positive. They're always kind of generating new ideas. We might kind of think of these as sort of the Tiggers of the world. You see this rewarded definitely in business and academia and other various places where having that kind of energy and ability to generate ideas quickly is sort of valued. And then on the other side of the pole, we have more dysthymic temperament. So these are sort of more your Eeyore type folks who, they don't really meet a criteria for clinical depression, but they tend to see the world a little bit through a cloudier lens, maybe a little more hesitant to take risks. And this also has value too. So, you don't necessarily want a hyperthymic uh, banker. Maybe you want a banker, your investment advisor who's going to be a little more cautious and a little less prone to flights of fancy, right? So because you don't want a hyperthymic surgeon. You want somebody who's cautious and maybe sees the potential risks. So, these are temperaments are not disorders. It's just more about how we're wired. So when we're talking to patients about bipolar disorder, we need to screen for it because typically patients are going to show up in our office saying that they feel depressed. Because generally when people feel hypomanic or manic, they don't feel like they need treatment. So the likelihood of them showing up in our office is fairly low. So we're going to mostly see people that have depression who are if they're on the bipolar spectrum, they're going to show up in our office when they feel depressed. So we're going to have to ask about this because otherwise they're probably going to focus on the most prominent symptoms, which for them are going to be their depression ones. So we need to ask questions like, have there been times in the past where you didn't need as much sleep, but oddly you had a lot of energy, and maybe the less you slept, the more energy you got? Um, Now people who've never had that are going to look at you kind of cross-eyed and say, what are you talking about? That sounds awful. But people that have had mania will say, oh yeah, no, that happens to me sometimes. And that's the first hint that I'm going to look for. Like, were you more active? Which is a more kind of plain language way of saying, were you doing more goal-directed activity? Were you starting projects? Were you creating new ideas? Were you creating new work? Um, Oftentimes when people are in that state, they can be kind of irritable because the metaphor I use with patients is it's like you have been given a Lamborghini that can do 120 miles an hour without even trying, and you're trying to get through highway traffic that's going 55 miles an hour. It's going to be frustrating. Everyone's going to be in your way. I also ask about behavior. I generally don't ask a lot about mood because, frankly, do you remember what kind of mood you were in 2 weeks ago? I don't. And so I do tend to remember periods when I had more energy or less energy. So that's going to stand out for somebody when you're doing screening. And you're also looking to see if there any kind of pattern or cycle to these sort of events and how long do they last. It can be helpful to get family members involved in this questioning process, obviously with consent of the patient, because they will often remember times where the patient had these elevated states, whereas the patient might see them as not really being a problem because for the patient's perspective, it may have been one of the times when they actually got a break from their fairly chronic depression, which I'll talk about in a moment. There's a couple of different screeners that you can use. The MDQ is the classic, tends to lean towards picking up more pure mania. So it's less helpful for picking up these more subtle states of bipolar disorder. The rapid mood screener is a newer screener that is designed really to try and help differentiate major depression from bipolar 1 disorder. I recommend considering both of them. I often talk about with patients and with colleagues about the idea that bipolar disorder is less of a mood disorder. We categorize it in the DSM as a mood disorder, but really, when you break it down to its phenomenology, it's a dysregulation of energy. So when people have a lot of energy, you can think of this as this sort of train car here, right? And so when the energy is going up, all these other associated boxcars, if you will, of symptoms are going to go along with it. And so things like their mood, obviously, but how much sleep they need, how much activity they're engaged in, how quickly they're thinking and talking, what's their impulse control like, what's their libido like. And then when the energy goes down, those things are going to tend to track with it. And so I really look for this sort of dysregulation in energy more than I do about mood. And this sort of makes sense because some of the emerging biology around bipolar disorder, like many illnesses, we have associated biological phenomenon with it, but we don't necessarily have a causative sort of nosology for explaining bipolar disorder. But one interesting finding is that when you look at the size of mitochondria, and I'll remember mitochondria from high school biology of being the powerhouse of the cell, right? That people with bipolar disorder actually have smaller mitochondrial size compared to healthy normals. And so this is interesting, right? If we have an impairment of energy regulation, it would make sense that that might track back to mitochondria. So stay tuned to this data. Now, how many people in the population have bipolar disorder? Now, you got to remember this is going to be different than what we see in our clinical populations because this is the general population. If you went around and you asked, 1,000 people if they had these symptoms, you would probably find somewhere between 1 and 3% of the population has some kind of bipolar symptoms. However, in a clinical setting, like in a psychiatry clinic, you're obviously selecting for people that have more mood disorders. So you're going to see more bipolar disorder than 1 or 3% of your clinical population in a psychiatry setting. And we sometimes think, when people start presenting with really highly recurrent, especially treatment-resistant depression, that it's worth asking yourself the question of, could this person be bipolar? And those symptoms have kind of been missed over the years. And the reason why this matters, a lot of times diagnosis, you can kind of spitball it, to be quite honest. Here's where it matters is that in bipolar disorder, there's a much higher risk of suicide attempts and suicide completions. The mortality rate of untreated bipolar disorder is around 20%. So that's a highly lethal illness. And fortunately, we have a treatment which will reduce the risk of that. And I'll give away the ending of the story and tell you what that is. It's lithium. We're going to talk a lot about lithium in a few minutes. But this is why it's really important to get this right. The other reason is that when we treat bipolar patients as if they have major depression and we throw a lot of antidepressants at them, at best, it doesn't work very well. And at worst, we actually make them worse. We can initiate often mixed states or sometimes more frequent cycling. But it doesn't, antidepressants, especially without a concurrent mood stabilizer, second messenger modifier drug, often actually cause more problems than they help. And so this is why it's important to get this diagnosis right. And you can see that the mortality rate in the general population is 26 times higher in patients with bipolar disorder than it is compared to the general population for suicide. So this really underscores the need to get this diagnosis correct and to treat it appropriately. Now, one of the misconceptions around my bipolar disorder, and when I talk with patients about this, they will often kind of say, but I have periods where I feel fine. I'm not either manic or depressed. And so it's really important to understand that people with bipolar illness don't just have one of those two mood states. So if we look at somebody with bipolar 1, this is somebody who gets classic mania. That's the differentiation between bipolar 1 and bipolar 2. A bipolar 1 person will have pure or euphoric mania at some point during their illness. A person with bipolar 2 has a lot of depression and can have hypomania, but never gets full mania. If you've had full mania, you have bipolar 1. That's sort of the diagnostic definition. So if we look at this over the lifetime, we see that about half the time in a bipolar person's life, they feel fine. They feel euthymic. They spend about a third of their lifetime feeling depressed and somewhere about 15% experiencing mania. But let's make an assumption that people don't come to see us when they feel well. When they're in that gray side of the pie chart here, they're not going to come see us because why would they? So let's assume they only show up in that colored section when they are symptomatic. What are they likely to show up with? Usually depression. Now, if you work in an inpatient setting or a psych emergency, you might see manic symptoms for sure, because that's often where those present. But generally, in your outpatient clinical setting, you're going to see bipolar 1 folks with depression, which means if you don't ask about a history of mania, you're going to miss it. With bipolar 2, it's even more of a challenge. So you can see here, this is really an illness largely of depression. Only about 2 or 3% of people's time is spent in any kind of slightly elevated or mixed state. So largely almost all depression is what you're going to hear about. And that's when they're going to show up in your office. 95 times out of 100, they're going to show up in this sort of depressed state. And that's what their history is going to indicate, unless we look more closely. So in this next section, I'm going to talk about how we begin to treat this illness. Thanks for your attention.